Good to be with you today and bring you a new GYN Garage. My name's Ed Pavlik, and I'm in Lexington, Kentucky, where weather is rather Londony. My colleague with me today is
Frank Lawton from London, UK, and the weather here is rather Londony, but it's getting a little bit brighter.
very good. Well, today we're going to consider a matched group of cases that receive surgery with and without neoadjuvant chemotherapy. This report was recently published in the British Journal of Obstetrics and Gynecology by a group of investigators in France. Frank, why do you think this paper is important?
Well, I do have a bit of skin in the game with this paper because the original idea of neoadjuvant chemotherapy and intervention surgery in ovarian cancer was conceived when I was a research fellow in Birmingham, and I was the first author on, I think, the first paper that really showed the possibility of using chemotherapy before surgery in ovarian cancer. It was work that we looked at from a physician called Emil Frey, who actually launched the idea of neoadjuvant chemotherapy in breast cancer and osteosarcoma about 10 years beforehand. And the idea of neoadjuvant chemotherapy was to reduce the incidence of micrometastases in breast and osteosarcoma, and possibly to make the surgery less morbid, with reduced morbidity. So that was the idea behind the paper that the study that we had. And obviously the idea engendered a lot of interest. There have been numerous papers on neoadjuvant chemotherapy after surgery in ovarian cancer, and a number of studies. Interestingly, when we first submitted the paper to the Green Journal, to Obstetrics and Gynecology, the title was in inoperable ovarian cancer, and the reviewers quite rightly said it's actually not unresectable or inoperable, it's unresected. And one of the arguments about numerous papers that have looked at IDS is that the surgery has been suboptimal. Certainly that was one of the arguments against the Chorus study, that the initial surgery was not what would be considered the most optimal. The operating time was too short. The results were not appropriate. And I think the paper that we're reviewing today actually tries to settle that one way or another by only looking at patients who had what would be considered optimal surgery, or at least the outcome of optimal surgery, with no residual disease, whether or not that was carried out by primary surgery or whether or not carried out by neoadjuvant 3 cycles of platinum-based chemotherapy and then surgery. And not surprisingly, the results have shown that the progressive-free interval and the overall survival in the 2 arms is pretty similar. Certainly there isn't one obvious advantage of one over the other, but the morbidity, the stoma formation, hospital stay, major complications of surgery are much reduced in the intervention arm, the neoadjuvant arms. So I don't understand now why people are continuing to not understand the ideas of intervention surgery. If the result is the same, i.e. after 3 cycles of chemotherapy, so we're talking possibly only 2 months difference, if the result is that a patient leaves the operating theatre with no macroscopic residual disease, whether that's by primary surgery or primary surgery and neoadjuvant chemotherapy with reduced morbidity, I think that's a good thing. When I was trying to explain this to patients, I would say that if you're making a gin and tonic, does it really matter whether the gin goes in before the tonic, after the ice cube, and before the lemon, or the other way around? And would anybody notice the difference? And I think that's a good way of looking at this. The end result of this is that a patient leaves the operating theatre with no macroscopic residual disease, possibly already having had 3 cycles of chemotherapy, which may have got rid of micrometastases. And I think this paper actually just continues to show that neoadjuvant chemotherapy and surgery in selected patients. I mean, obviously, if you feel that you can excise all tumor by first surgery, then that's something that obviously needs to be considered. But if you think that you could excise all tumor without removing a large amount of organs that would lead to increased morbidity, then I think this is something else that needs to be considered. I think there's enough randomized data now. There are at least 4, possibly 5 randomized studies. They've never shown a real inferiority for the neoadjuvant intervention surgery, and they've shown a definite superiority from the point of view of morbidity. And that's where I stand on this paper.
Sure. Let me just point out to everybody the paper that started it all, which is your paper. And this was done back when you were very young.
1988, yes.
1988. But it did start everything. And it deserves to, for us to give it a mention. Now let's go to this current paper, and what they really emphasize is that they're going to try and equalize things, and they're going to do that by a thing called the propensity score, and in so doing, they're going to see if the question that you've identified, is there any difference in survival, really holds up. And one of the things I'll point out about the propensity score is that there's only one component that gets equalized out of all the components that get equalized that really makes a difference, and that's with regard to stage. And if you look at really what happens before and after the propensity score equalization, this is really over here in pink outline, the one that gets improved the most. So with that in mind, what we also can look at in this paper is the survival curves that they come up with. And I feel that if you look at that top curve that's on the screen right now, which is the survival curve, the bottom curve, or B, is the recurrence-free interval, there's about a 10% difference, and it favors primary debulking. The question I would raise, if this data is significant, is what would be the reason, for that? And so in other words, when you have more complications and you're not using neoadjuvant, it seems that there is a slight improvement in survival going out after, let's say 5 years is where it occurs. So probably the cases, I guess the easiest answer I would provide to this is the cases where neither the completion of neoadjuvant or the survival due to an additionally complete resection, those people probably don't survive in the short term being less than 4 or 5 years. And those that got a better exposure to chemotherapy in a neoadjuvant setting, as well as a more complete surgical outcome, they start to appear later in the course that's being followed. So that's the only spin I would put on this, that it's very hard to do the match. And if you look at how closely they match, it's within 5%. But the only big match that I think was meaningful was with regard to the stage 3 various cancers.
I think you're right, and it may well be, of course, that. And I think Neville Hacker produced a paper many, many years ago about the amount of disease before surgery. And clearly there could be a group of patients within the intervention group who started with, although it's stage 3, it's very bulky stage 3 rather than a more spreading type of stage 3. And clearly if they start with more bulky disease, even though the disease may disappear with neoadjuvant chemotherapy and surgery, the micrometastases, the spread of disease, is still there. So it could well be that the patients who had intervention surgery were actually the ones who had a poorer prognosis from the point of view of their initial disease bulk at presentation. And clearly they can't answer that on or haven't answered that on in this paper. But yes, Yeah, I think that's a well-made point, actually. I agree. Yeah, there is some difference, but I don't think that you can actually say, well, one surgical intervention is inferior to the other based on these data. Perhaps there should be another randomized study. I don't know. We can go on forever with these sort of things. Clearly, and I'm not arguing against it only because it hasn't been proven. A patient who leaves the operating theatre with no disease that one can see will do better than the patient who doesn't. How you reach that point and how quickly that point is reached is still open to debate. Should we be giving 3 cycles or 4 cycles of chemotherapy, etc., etc. But certainly, I'm sure there's room for lots and lots of continuing research into this problem.
Absolutely. Well, once again, I think we are in agreement about what's happening here, and we finished off another Gynec Garage. So it's good to see you, Frank. We'll look forward to doing this again.
Indeed. Yes. See you soon, Ed.
Okay. See you soon.
Bye-bye now. Bye-bye.